I like your background.
You like that?
Yeah.
You'll see why I chose that one here in a minute.
Okay.
Welcome, everybody. This is going to be the first of 5 live Zoom lectures on the heart, the cardiac system. So it does a lot more than just help you fall in love. We are going to go through some PowerPoints. This PowerPoint is available on your week 5 module list. So you can go through just the PowerPoint if you want. You can download it, scribble on it, draw funny faces, do whatever you want to. I will go ahead and begin. What time is it? It's 9:01. So there are individuals who have not yet taken the midterm, so we cannot discuss the midterm during this session. But during my Friday hours, we can do that. Or during Danielle's office hours, you can do that. So that being said, we're going to move on, and we are discussing the concept of perfusion. Perfusion as it relates to the cardiovascular system. Now, as you guys might have caught on by now, concepts are a lot closer aligned with nursing diagnoses. Systems like cardiovascular system, respiratory system, things like that are more closely aligned with pathophysiologies. That's why we like to use concepts, because it's closer to what you're going to be doing as a nurse. And you'll get a lot more of that when we get into nursing care plans and start talking about those. But as we move through the slides today,
recording in progress.
Why is my, oh, there it is. This little guy here, if you see him in one of the slides, you might want to remember what he's pointing to, because you might see it again. Nod, nod, wink, wink. Moving on, this lecture, hopefully it'll be short and sweet. Most of you have already had anatomy physiology, but I want to go back through it again. Very, 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 very important that you understand how the heart works, because, well, first of all, the #1 killer in the United States today is cardiac disease. So probably at least 3/4, if not 4/5 of your patients will have some type of cardiac involvement in your care for them. So you really need to know the proper flow of the heart. You need to know how the electrical system works. You need to know how the muscles work, and you need to know how the perfusion of the heart works. Fortunately, since we have 5 weeks, we can break those all up into separate pieces and spend a little time on them. Now, the concept of perfusion, basically what we're talking about is the passage of oxygenated capillary blood through the body tissues. Now, as you had in the last following weeks, respiratory, that's where the non-oxygenated blood goes into the lung, and you get rid of the CO2 and you pick up the oxygen and you go back to the heart. We're going to talk about where it goes from there, which is into the body. But we still have to talk about the lungs because they're part of that whole cycle. Oh, you might see that again. What is the cardiovascular system? It's a big pump, is basically what it is, in the middle of your chest, about the size of your fist, and it serves 3 functions. One of those functions is it supplies oxygen to the blood. It supplies oxygenated blood to the body's tissues. This is probably the #1 thing that the heart does, is after it picks up the oxygen from the lungs, it gets that oxygen out to the body, because we all know without that oxygen, you die. And probably the most vital organ that it supplies oxygen to is the brain. Now, I don't know if they covered this in CPR or not, but when you're doing CPR on a patient, you're not keeping the lungs alive. You're not even keeping the heart alive. In fact, we really don't care about those 2 organs. What you're doing with CPR is you're supplying oxygen to the brain, because you're keeping the brain alive. Without the brain, there is no existence, basically. So getting oxygen to the brain is probably priority number one, but then getting oxygen to the rest of your body and its organs is definitely priority two. It's also picking up the carbon dioxide in the body and moving it back to the heart and to the lungs. Now that's carbon dioxide is a waste product. For those of you who got to look at the wonderful Krebs cycle, everybody remember that? Every little detail about the Krebs cycle? They tortured us with that. But it's also taking nutrients from the body, from the small intestines, moving it up into the heart and then out to the rest of the body and the cells throughout the body. So basically you're picking up oxygen, you're getting rid of carbon dioxide, and you're moving nutrients through the system. So you got, those are the three things that the heart does. You might see that again. Let's jump into the anatomy of the heart. When it comes to the actual mechanics of the heart, you're going to have basically 4 different sections. And I know some of this might be redundant for you. You've probably seen it before, but we want to cover it just to make sure. You have the atriums. You have the right atrium and you have the left atrium. These serve a couple purposes. One of those is to supply fluid moves from high pressure area to low pressure area. And that's how we get fluid. There's a couple ways you can move fluid. One of them is by pressure, contracting the muscle. And that's how your body moves the blood from your veins back to your heart. That's also how the left ventricle, how that heart moves fluid into your body. Another way you can move fluid, though, is just to create a negative vacuum, which is basically what the right and left atrium do. They provide a negative environment for blood to flow into. So basically it becomes a pre-pump in the heart. So when your used blood comes in through your superior vena cava or your inferior vena cava, which you can see right here. These are the veins that lead back to the right atrium. The blood just kind of pools in there. And then the atrium can contract and shove it down in the ventricle. And the ventricle is the main pump that then pumps it to the heart or pumps it to the lungs or pumps it to the body. Now the ventricle is the main pump. And as you probably know, if you don't, you should know that the right ventricle pumps the blood up to the lungs. And the left ventricle pumps the blood out to the body. So that's two important things you need to remember. That'll become significant because if you're having trouble with your right ventricle, you're probably going to have some trouble with your lungs and oxygenation. If you're having trouble with your left ventricle, you're probably going to have some trouble with your body tissues, edema, things like that. So that's how you can correlate the symptoms back to, is he having a right side heart failure or left side heart failure? I'll tell you right now, 90% of people out there, the left ventricle is pumping the blood to the body. It's the biggest muscle. It's the one that works the hardest, and it's usually the one that goes first. So the left ventricle is going to cause a lot of problems, especially in things like congestive heart failure. The septum, septum is just this wall down the middle here that divides the two. Where that is significant is in small babies. When you are a baby, there's a big hole right here because your mama's doing all the work for you. So the blood basically just passes right through the heart. Doesn't really do much. As you are born and begin to grow, this hole will get smaller and eventually the hole will close up. Sometimes there's a problem. And so in some babies, they have to actually go in with surgery and close that hole up. Otherwise, the non-oxygenated blood is mixing with the oxygenated blood and they're pumping basically used blood out into the body, and the child is not getting enough oxygen. So I'm sure probably some of you have heard of that operation before. I can't remember the exact name of it. Anybody remember? Atrioventricular septum defect or something like that? I don't know.
I just remember we do the chronic congenital heart defect test to test for it.
Yeah. I'm not sure what test they use on that. Seems like an X-ray or an MRI would be best for that. But in adults, the septum usually doesn't present us with a whole lot of problems, except maybe when we get to the electrical, but we won't worry about that right now. Now, valves are another part of the heart. You got 4.
Back to back. Itu kan class.
I'm sorry? I'm sorry, did you have a question? No, okay, never mind. You have the pulmonary valve and you have the aortic valve. Where are they? These guys right here. Here we go.
Record.
Now, these are the valves. These are near the top of the heart. And when the ventricles contract, this is where the blood goes. For the pulmonary valve, when the right ventricle contracts, it goes to the pulmonary valve and the blood goes into the lungs. When the left ventricle contracts, it shoots the blood through the aortic valve and it goes through the aortic arch and into the body. Here's the aortic arch right here. When you are in, everybody knows systolic, diastolic, lub, dub, lub, dub. When you're in systolic, lub, the heart contracting, that's your ventricles contracting, pushing blood out. These valves are going to be open. So then when you hear dub, the heart relaxing, those valves are going to close. So when you're listening to somebody's heartbeat, what you're actually hearing is you're hearing those valves closing. So when the heart goes lub and then dub, dub is when the pulmonic valve and the aortic valve are closing. And that's what you're hearing. There's also valves between the atrium and the ventricle. These are the tricuspid and the mitral valves. Now, during dub, these are open.
The due date because people didn't take it.
Sorry? Okay, be sure your mic is turned off if you're talking to your kids or whatever. When the ventricles relax and open up, these tricuspid and mitral valves open up and allow the blood from the atrium to flow into the ventricles. And then when the heart contracts, those valves close. So these are the valves you hear during the lub part of lub dub, lub dub. And that's because when those ventricles contract, they don't want to shoot blood back up into the atrium again. You know, the right ventricle doesn't want to shoot the blood into the right atrium. It wants to shoot it up through the pulmonic artery and into the lungs. So these valves are closed during the lub part of the lub dub. Now, I'm sure you probably, I don't know if you've been exposed to lung sounds or not, but we have the S1, S2. S1 is the lub, S2 is the dub. You know that, and you're hearing 2 sets of valves close, 2 sets of valves open, or close, 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 close. That's your lub dub, lub dub. Sometimes things will get out of whack, and that is when you get your S3 and S4 sound. Have you guys been exposed to those yet? S1,
No,
S3, S4?
No.
Okay, well, we will cover those in the future, especially when we get to head to toe assessment. When you have an S1 and an S2 are normal. S1 is your lub, S2 is your dub, but you can sometimes get other sounds in there, like you get an extra sound, like lub, dub, dub. That's an S4. Well, that means that on the dub part of the lub dub, the valves are not closing at the same time. And then you have an S3, which happens actually before the lub dub. So it's like a lub, lub, dub, lub, lub, dub. That's called an S3. And that's because those 2 valves are not closing at the same time. The tricuspid and the mitral are not closing at the same time. It's not real important that you know which valves are opening or which valves are closing during lub or dub, but I find that by understanding that, it helps me understand the mechanics of the heart a little better, especially when it comes to memorizing the S1, S2, S3, and S4 sounds. Okay, just let you know. After that, we get out of the mechanics of the heart, and now we're getting into the actual getting into the perfusion of the heart. Before we do that, and that is the arteries and the veins that go through the heart. I'll talk about that here in a little bit. And then last but not least is the conduction system, the electricity that makes the heart contract. And we will go through that as well. Here is a simple chart for how the blood flows through the body. We'll start with the body. I've just ran 1.5 miles. I'm all out of oxygen. My blood is deoxygenated, and we usually call that blue blood. I really don't know if the blood is actually blue or not, but you know, whenever you cut yourself, a vein has blue blood in it, but when it bleeds out of your body, it hits the oxygen and turns red. I'm not sure how blue it really is. Anyway, who cares? Blue is the deoxygenated blood. It's going back to your heart. It's going to go up through your inferior vena cava or down through your superior vena cava if it's coming from the head, and it's going to drop into your right atrium. Now, the right atrium will contract and shoot that blood through the tricuspid down into the right ventricle, which will then contract and shove that blood, that blue blood, up into the lungs. And there it will get its oxygen and turn into nice, fresh, healthy red blood. Get rid of the CO2, bring on the oxygen. After that, it drops the blood into the left atrium, which contracts through the mitral valve into the left ventricle. And then the left ventricle contracts, goes through the aortic valve, goes through that big aortic arch in your body over here on the left side, and shoots that nice, juicy, red, oxygenated blood back into the body. So if you ever get confused as to the mechanics of how it all works, this chart would come in handy. Oh, you might see that again. Moving on. Now here again, how it actually works. The blood flows in from the body into the right atrium. From the lungs, it flows into the left atrium and it fills these up. And then you get the atrium contracts, and it's I was going to say something, I forget what it was. But anyway, the atrium contracts and then shoots the blood into the right ventricle and left ventricle. And then after that, the ventricles contract and force the blood in the right atrium goes up to the lungs. The left ventricle goes out to the body. That just simple blood flow. Okay, getting back to it. Oh, I kind of already went through the ventricles, so we don't have to worry too much about that. Here's the tricuspid, and there's the mitral. I already talked about that. So anybody have any questions on the atriums or the ventricles before we move forward? Pretty simple, right? How about the valves? Any question on the valves before we move on?
No,
All
No
right.
questions.
no questions.
You have a question? No? No, okay.
No.
All right. I can't see any faces, so I don't know who. At least I don't have to worry about that one student sitting in the very back of the room with their cell phone going. Moving on. Okay, now let's get into the perfusion of the heart. Now, the heart is a muscle, and like any muscle, it needs oxygenated red blood too. It burns it all up and deposits CO2 and waste products into the blood, which then goes back to the right side of the heart to go to the lungs and be oxygenated. These are the four main arteries of the heart. And what happens is after your left ventricle contracts and shoves the blood up into the aorta to go out into your body, a little bit of that blood is siphoned off and goes into the arteries of your heart. And there's 4 main ones, and then there's a million little tiny ones that branch off of this. But, and we'll talk more about this when we get to perfusion of the heart. And then we'll talk even more about that when we get to ECG reading on the electrical of the heart. All of this kind of intertwines. So you're going to get a little bit of it here and a little bit of it there, but it all kind of plays together. But the right coronary artery comes down basically the front of the heart, and we call that the RCA. And the reason I'm giving this to you is you're going to hear these terms thrown around just so you're familiar with them. Don't bother memorizing them, but you know, they're going to, oh yeah, he had a partial infarct of the right RCA. And you're going to look at the nurse and go, like one of those puppy dogs, you know, when you're talking to your dog, they go, I don't want you to do that. So when they say RCA, they're talking about the right coronary artery, and they're always talking about a heart attack, a myocardial infarction. And then there is the left coronary artery. These are the main branches off the aorta, go down each side. And then from the left coronary artery, there's another one that wraps around to the front called the circumflex artery. We call that the circ. You know, someone had a heart attack. Oh yeah, he had a plugged circ. That's what they're talking about, the circ. Or the left anterior descending artery, which goes around the back side and goes down. This goes down, wraps underneath the heart. Sometimes you hear them talk about an inferior wall MI. But what they're talking about is inferior means lower wall, the wall of the heart. So they're saying that one of the veins on the bottom of the heart got plugged, and inferior wall MIs are pretty common, especially in women. And we'll talk more about that in the future. But when somebody is standing around Walmart and they start sweating and feeling bad and says, I feel like I've got an elephant sitting on my chest. And all of a sudden they grab their fist, they throw it against their chest, and then you see their eyes roll back in their head, they're having a heart attack. And what that means is one of these vessels is plugged, and all the muscle down below that vessel is not getting any oxygen. And when it doesn't get any oxygen, it gets very irritated, it gets very upset, and it goes crazy. Now, this is what's called a myocardial infarction. Myocardial meaning myocardial muscle, infarction meaning plug. An infarct just means plug. So this is your classic heart attack. This is when the person rolls over, flops down in front of you in Walmart, and you start doing CPR and screaming for 911. This is a heart attack. So that's what that's what happens is we race them off to the lab. Hopefully they get into the cath lab, and the cath lab sends a big catheter up their aorta into this vein, and it goes here and goes, oh, there's the plug. And it gets in there and it cleans out the plug, and their heart gets oxygen again, and they're all happy, and they're thanking you because you did CPR on them in Walmart. So that is why it's important that we kind of understand what the perfusion of the heart is, because you're going to be dealing with a lot of people who are post-MI, or they've had a heart attack at some point in the past. Or they have coronary artery disease that's plugging these up slowly, and they get things like angina, which is chest pain, but it's not a full-on heart attack. Well, we'll talk more about that when we get to perfusion. Last but not least, electricity. There is an electrical system in your heart, and that is what makes these muscles contract, because we all know without the electrical current, the muscles don't contract. We have 2 major nodes in the heart, the SA node, sinoatrial node is the full name for it. And this is your main pacemaker. This guy sends out a signal anywhere from about 60 to 80 beats per minute, whatever your heart rate is. And the signal goes down into the atriums, and it causes the atriums to contract. Then the signal continues down over the wall of the atrium and goes into called a bundle of His. Bundle of His is just where the signal comes out of the atriums and it goes to the septum of the heart. And this is where it sends it down through your heart. Now, this area here is not causing any heart to contract. This is just a channel for that electrical signal to get down here to what we call the Purkinje fibers. The Purkinje fibers are what branch out and actually ignite and make your ventricles contract. So it goes from the SA node to the atrium contracts, then it goes to the AV node, through the AV node, down the bundle of His into the Purkinje fibers. There's a left bundle branch that goes to the left ventricle. Excuse me. Try that again. There's a branch that goes to the left called the left bundle branch that goes to the left ventricle. The right bundle branch goes to the right ventricle. That basically what we're just saying is it splits into two branches. Then it goes to the Purkinje fibers, which then ignite. So that's tracking the electrical of the heart. Pretty simple. So what's with this guy? Well, if for some reason the SA node quit working, this guy, the AV node, can take over. So it's almost like a backup pacemaker. Sometimes individuals will get what's called atrial fibrillation or atrial flutter. And what's happening is there's too many places that are irritated in the atrium. And if you take any part of the muscle in the heart and you stretch it or traumatize it in any way, it's going to start firing off electrical signals and contracting on its own, which is really weird. So basically, any muscle in the heart, any area in the muscle of the heart can act like a pacemaker, which is kind of weird, but that's how it does it. So if you have atrial fibrillation, your atrial muscle has been traumatized in some way, and this puppy is firing off, and this guy is firing off, and the SA node is firing off, and basically your atrium, not knowing what to do, is just going and panicking. Now, when all those signals get down here to the AV node, it goes, wait a minute, something's not right. And it starts firing off its own signal to the heart. Now, the AV node normally runs a little slower than the SA node. So if your SA node is clicking along about 80 beats per minute, the SA node will probably click along about 60 beats per minute. And this is nice because if all these signals from the atrium got through to your ventricle, then your ventricle, just like your atrium, would be going. And what does that mean? That means heart attack. That's when you put your fist over your chest, your eyes roll back in your head, you fall down in Walmart and somebody starts doing CPR on you. So the AV node really does protect us. There are many individuals out there in the world today, myself included, who have atrial fibrillation. So when that atrium starts going crazy, this AV node protects us and makes sure that our ventricles are still clicking along at a normal pace. Now, when we get into the electrical system in week 7, I will talk more about atrial fib and give you some more details on that. But just know that there are 2 pacemakers in the heart. The SA node is your primary, your AV node is your backup. Now, if I hit this, look, we got the little Cupid again. Now you see why I got this background for my wallpaper, right? Moving on, cardiac output. You may run into that. Cardiac output is the heart rate times the stroke volume. Okay, what does that mean? Well, the heart rate, that is your heartbeat. If your heartbeat is 80 beats per minute, then your heart rate is 80 beats per minute. But that combines with stroke volume. And the stroke volume is how much blood in this left ventricle is being pumped out into your body. Excuse me. Now, the reason this is important is you have to have a sufficient heartbeat and you have to have a sufficient volume of blood coming out of your heart to have a sufficient cardiac output. If your heartbeat's normal, but you're not pumping much blood, like in the case of congestive heart failure, where your muscle just isn't working as well anymore, that 65 may be 45 or 30. So your cardiac output is going to be low. Now, the same is true if your heartbeat is low, but you do have a normal stroke volume. You have a normal amount of blood coming out of the heart, but your heart's going too slow. That also is going to drop your cardiac output. The reason this is important is if somebody's cardiac output is low and they're getting lightheaded and dizzy all the time and they're short of breath, we need to figure out, is it their heart rate that we're having trouble with? Or is it the amount of blood that they're pumping that we're having trouble with? The heart rate you figure out just by doing a pulse. The stroke volume or the cardiac output is usually we use an ultrasound to look at their heart and tell us how much blood is actually being pumped out of the left ventricle. But you might run into cardiac output again, so I want to throw that in there. So remember, heart rate times stroke volume, basically how fast the heart's going, how much it's putting out, will tell you what their cardiac output is. Very important number. Now, when it comes to assessing people on their cardiac history, there are several things we need to cover. Do I go into more detail? Okay. Basically on the assessment. Now, this is where you're sitting down and you're talking to the patient. You're going to get their history. You're going to do a physical assessment on them, and then you're going to do or look at their tests. You can't, you can do the history, you can do the physical assessment. The diagnostic tests have to be ordered by the doctor. EKG, ultrasound, labs, all that, x-rays, that all has to be ordered by the doctor. But once those tests are ordered and you get the results back, you can use those to form a picture of your patient. History, let's look at history. Patient's medical history. First of all, has this patient had any history of cardiac disease or problem in his past? The older people will know that. Younger people, probably not, you know, unless they had some special medical condition when they were young. But what's also very important is the patient's family history. If their father died of a heart attack at 57, that can be an issue. If their family has a history of high blood pressure, my brother's got high blood pressure, my dad has high blood pressure, so guess what? I've got high blood pressure. That is a risk factor. So remember, don't ask just about the patient's medical history. Ask about the patient, the history of their family as well. That's going to tell us a lot, especially in cardiac disease. Other diseases, not so much. You know, does your family, have you gotten the flu before? Does your family get the flu? Well, who cares? There's nearly no connection there. And there again, that falls back on genetics. Genetically, people inherit high blood pressure. And there's other genetic factors, high cholesterol, things like this. So that can be related to family. Culture as well. There are certain cultures that are prone toward higher blood pressures than others. And cardiac disease. Asians are pretty much historically lower on the cardiac disease level, but African Americans tend to run a little high on the blood pressure side. So cultural differences, not just genetically, but you also have to look and see what diet those cultures have can definitely affect whether or not heart disease is a problem. For example, culture, American culture, we eat very high carbohydrates and we have a very high level of cardiac disease. There's a correlation there. Whereas people say from Italy or places like that eat a lot of vegetables and such, you know, you heard about the Mediterranean diet, especially Middle Eastern, they don't eat as high a carbohydrate diet. So their culture may not be as prone to heart disease as the Americans are. Physical assessment, general appearance, vital signs. General appearance, short of breath, sweating, you know, things like that. And of course, the vital signs. Somebody in distress, their heart rate's going to be higher. People with high blood pressure are going to have a high blood pressure, obviously. That's kind of easy one to figure out, right? There are some other things like you can check the eyes, but I have never used that. I know it's in the textbook and they make a big deal out of it, but I've never used it myself, so I'm not going to touch on it. Cardiac rhythm, when you listen to their heart rhythm, basically auditorily, all you can determine with their heart sounds are they regular or are they irregular? You can also listen to see if there's any heart murmurs, and that's valves that don't shut properly, so you get a swishing sound. And the S3 and the S4 sound. And we will talk more about those when we get to physical assessment. I'm not going to test you on those right now. Peripheral pulses. If peripheral pulses if are stronger on one side than the other, that can indicate some problems. Peripheral edema. People with heart failure have a tendency to collect fluid. Their feet will swell. You'll see that a lot in heart failure. Weight. Are they gaining weight or losing weight? Lung sounds. If your right side heart is not functioning properly, or actually it's more in congestive heart failure, we see that a lot. You're going to hear fluid in the bottom of their lungs. If their heart is not pumping properly, the blood is going up to the lungs, but it's not getting pumped out properly. And the plasma seeps into the lungs and you will literally hear fluid in the bottom of their lungs. We call that crackles, basilar crackles. And that's something when you get to clinical, you want to keep a good lookout for. You want to hear that because you're going to run into it a lot. Mental status, when you're not getting the oxygen you need, you can get loopy. Moving on. Heart sounds. Okay. I've pretty much I just finished talking about that. Here are the 3 things that you can determine with your stethoscope. Is your heartbeat regular or irregular? Now you hear people throw this term around a lot. I didn't mean for that to do that, but it did anyway. Normal sinus rhythm. Normal sinus rhythm can only be determined with an ECG. That means everything in the heart rhythm is perfectly normal, and you've seen it on TV and everywhere else. We will talk about that when we get to the electrical system. If you hear somebody put the stethoscope on their chest and they say, well, they're a normal sinus rhythm. Yeah, you can't really say that because you haven't looked at their ECG. So don't do that. You can say they're regular or they're irregular. You can listen for S3 and S4 sounds, and you can listen for murmurs. Those are basically the only 3 things you can listen for with the stethoscope. Anything beyond that, you have to hook them up to an ECG or an ultrasound to see what else is going on. Some diagnostic tests that we use for cardiac disease. Well, one of them is chest x-ray. And what does a chest x-ray tell us? Well, in heart failure, your heart is stretched out of shape. And radiologists, even basic first year radiologists, can look at an x-ray and say, yep, that heart's too big. They have heart failure. They have congestive heart failure. When you want to start looking at the valves and other mechanical problems, you'll have to do other diagnostic tests like CT and MRI. But the radiology is good for the actual muscle, the mechanical problems. When you get to the electrocardiogram or ECG, we used to call it also EKG, and you'll probably hear people use that. That's okay. EKG actually comes from the German translation of echocardiogram, the Echocardiographis or something, whatever they call it, but they spell cardio with a K. So Americans, I think probably when it first came out, got used to calling it an EKG. But technically speaking, it's an ECG. Either title works. No one's gonna beat you up for saying EKG. In fact, I still find myself doing that myself once in a while. Grab the EKG. Grab the ECG. There's basically 2 kinds. Well, there's the stationary one and there's the ambulatory one. But on the stationary, they use it 2 ways. One, you're just lying in a bed and they hook a bunch of leads up to you and they look at your heart. Or you can go to your cardiologist and get a stress test where they stick you on a treadmill and they try to stress your heart while they look at the ECG. I got it right that time. I almost said EKG. Or they can pump if you are not capable because of weight or bad legs or whatever. If you're not capable of getting on a treadmill, they can give you a drug that stresses your heart. I really don't like that route. But anyway, they want to see what your heart does under stress. So that's why they do a stress test. And you'll hear that thrown around a lot. You'll hear that term a lot. Oh yeah, he went to the cardiologist for a stress test. Well, now you know what the stress test is. Every once in a while you hear somebody talk about, now this one here, the stress test and the stationary are usually looking for heart disease and mechanical problems with the heart or perfusion. You know, have they had a heart, have they had a vessel blocked in the heart causing problems? And even though we're using electricity to determine that, and we'll cover that. I probably just wrapped myself around a tree I didn't need to do. But anyway, we'll talk a lot more about that when we get to the electricity of the heart, as to how electricity tells us what's going on mechanically. It's kind of cool. You're going to like it. Every once in a while, they might want to put an ECG on somebody over a long period of time, in which case they'll take this ECG machine and strap it to your chest, and it's called a Holter monitor. You'll hear that thrown around a lot as well. This is really good for things like intermittent problems. One good example of that is atrial fibrillation. Remember when I was talking about that, the atrium kind of gets weird. Sometimes your atrium will get weird for like 5 or 10 minutes, then go back to normal. And then you're going through the day and things like stress will bring it on, and your boss yells at you, and then suddenly your atrium is getting weird again. But then you go to the doctor and your atrium goes back to normal. So your heart is a lot like the engine in your car. You'll hear a weird clicking sound in the engine, but then the minute you pull into the garage mechanic, it goes away. And the mechanic looks at you like you're crazy. And then you drive off the lot and you drive home and the click comes back. So the Holter monitor helps us detect that. If we suspect somebody has atrial fibrillation, but it's intermittent, we can put the Holter monitor on them and it records their ECG over a 24-hour period. And then the doctor can look at it and see, oh yeah, you have intermittent atrial fibrillation. The reason that's important, I'll explain to you during week 7 when we talk about AFib, because you treat intermittent differently than you treat full-on chronic atrial fib. And the last test, and I hesitate to really say this, but cardiac catheterization can be used as a means of looking at your heart and seeing if there is anything wrong going on. We usually don't do that because it's very, very expensive to use it as a diagnostic tool. We usually wait until you actually have a heart attack before you go to the cath lab. Christy, did you have a question?
Yeah, I was just going to ask, is the Holter monitor the same as what they call the tele monitor, which is the smoke over fire, sky over grass, and then the brown in the middle? Is that what that is?
That is hooked up the same way. All the ECG and the Holter monitor are hooked up the same way. But when you talk about telemonitoring, that's usually used in the hospital. And basically, it is an ECG. It's just a regular ECG. The only difference is we put a box on their chest like the Holter monitor, but instead of the signal going to a little ECG monitor by the bedside, it goes into the internet and goes to a monitor where usually a cardiac tech is sitting. So if you have 14 patients in a ward that are on an ECG monitor, all of them can be wired to a central station where this one person can sit there and look at everybody's ECG. And it's just a way for one person to monitor multiple patients.
Right. Okay.
So you might hear a cardiac tech or teletech. It's usually a person, not necessarily a nurse. It could be a nursing assistant or anybody that's been trained in that particular thing. They'll sit at a monitor and watch several people on their ECG monitors.
They have them in the ICU.
Yeah. Now, normally with ICUs, especially cardiac ICUs, well, actually all ICUs, is you'll not only have the patient hooked up to an ECG in the bedroom or in their patient's room, but that signal is also transmitted back to a central station where either the nurse can watch it or a technician can watch it. And so you always have their eyes on their ECG monitor. And what they're doing is they're just looking for when something goes wrong or goes wacko, somebody's got eyes on it, so you can rush into the room and take care of it. Any other question on that?
No other questions. Thank you.
No.
All righty. Good question. Moving on. Now, here are our labs. When it comes to labs, there again, what are we looking for? Are we looking for mechanical problems? Are we looking for risk factors, et cetera, et cetera? When somebody goes to the doctor and the doctor wants to see if they are at risk for having cardiac problems, there's a couple things they look at. They look at their cholesterol and they look at their triglycerides. You all probably heard of cholesterol, the HDL and the LDL. HDL is your good cholesterol, LDL is your bad cholesterol. You want your HDL to be high, you want your LDL to be low. You want your triglycerides to be low as well, because the theory is that cholesterol and triglycerides will build up the plaque in your arteries and eventually lead to cardiac problems. And I'll discuss those more when we get to those particular specialties. So that's more of a risk factor as not so much a diagnostic, if you know what I mean. ABGs, you got beat over the head with ABGs in the first 5 weeks. At least I hope Danielle beat you over the head with ABGs. That's basically just going to show how well you're oxygenating. If your ABGs are out of whack, it can be a cardiac problem. It could be respiratory, it could be cardiac, it could be metabolic, it could be any number of things. But sometimes the ABG will kind of tip you off if there's something, say, going on with your right ventricle. Now, when somebody does come in with chest pain and you want to run diagnostics on them, that's when we get into the cardiac enzymes. Now, cardiac enzymes, it's really pretty simple. When you're having a heart attack, part of your heart muscle is being deprived of oxygen, and that tissue is dying. When tissue breaks down, it will release stuff into the bloodstream. In other words, the cells die, they release their contents. And myoglobin, troponin, and creatine kinase are products that are released on muscle tissue damage. Now, creatine kinase is a very important part of muscle, all muscle in the body. So if you have a bodybuilder and he's just pumping really hard, and those who are into fitness know the whole purpose behind doing heavy weights is to damage the muscle so it goes back and builds the muscle bigger. So if you have a bodybuilder who walks into the doctor's office and gets labs done, his creatine kinase or his CK may already be a little elevated. So it may not necessarily be the heart muscle that's damaged. So the CK and the MBCK are not the most accurate tests for heart damage, but we still look at that. It's really high in crush injuries too as well. Myoglobin is the same case. It's a byproduct of tissue damage. But the one enzyme that is unique to heart muscle alone is an enzyme called troponin. So when somebody walks through the door with chest pain, one of the very first tests we run on them is a troponin test. In fact, we've even have it down to a portable unit now so that we can actually test them in the ER instead of having to send their blood to the lab. But troponin in a normal person is normally extremely low. I think it's 0.1 or less. But if that troponin level is elevated, that's usually a clear indication that there is muscle tissue damage to the heart. So EKG and troponin are like, did I say EKG? I did, didn't I? ECG and troponin are like the first two tests we run on a patient when they walk through the lab and they're complaining of chest pain. Now, in addition to that, you have just your standard labs, your CBC, your electrolytes, et cetera. These can help diagnostic, but they may not be specific to the heart. So they're just kind of supplemental tests. But that troponin is important. Oh, I thought I had a little angel for that. I don't, but anyway, you might want to remember that.
You do on the one that, like, I printed the PowerPoint and it has it on mine, the little angel.
Oh, does it?
Yeah.
Wonder what happened to my angel. Where's my angel? Anyway, I'll go back and fix that. But I mean, if it's bold and underlined, it's something you might want to remember. And bear in mind, I may use all of these for test questions. I may not. So that may be on the test or it may not. You don't know, so it's best you know it. I am evil. Anyway, here are medications that we can use for people who have already had a cardiac incident. I'm just going to throw these out here. You don't need to know much about them now because, like it says, we're going to talk about these in week 6, week 7, and week 8. And there we will get into more detail on each of these. But I just want to kind of give you an overview of the fact that these are medications used for cardiac. Week 6, which is the perfusion of the heart. Anticoagulants. You know what anticoagulant does. An anticoagulant keeps you from coagulating. So it helps prevent that little plug in the heart that gives you a heart attack. Those are usually used in the hospital. Things like heparin, which we will talk more about in the future. At home, we might give you something that's more antiplatelet. When you're on an anticoagulant like heparin or warfarin, it requires very close monitoring. Antiplatelet can do the same thing for you, but it doesn't require any monitoring. One example of an antiplatelet is aspirin. Baby aspirin. Take a baby aspirin every day if you are at risk for a cardiac problem. Another one is Eliquis. Eliquis is a little more sophisticated. It's designed to replace warfarin and Coumadin. It is a prescription medication, but it's a little more powerful than the baby aspirin is. Another one is vasodilators. There are some drugs like nitroglycerin that will just open up your vessels. You will often see guys in the movies, you know, my chest is hurting, and they pull out this little tiny bottle and there's this little tiny pill and they throw that under their tongue and then they go, I feel better now. Well, that's nitroglycerin. And you can get it in the little tiny pill form at home, or in the hospital, we have it in the big bottle. We have it in a bottle because it reacts to plastic, so we can't put it in the plastic bags like you do with normal saline. But what that does is it opens up your blood vessels so that your heart can get more oxygen. And again, we'll talk more about nitroglycerin in week 6. Week 7, we're talking electrical problems. That's where you have dysrhythmias, where your heart does weird things electrically. There again, we were talking about atrial fib, atrial flutter. There are medications that help your heart stop doing that. I take one that's called flecainide. Flecainide keeps the atrium from going crazy. And it works very well. I've been on it for like 15 years, never had a problem. So it's a really good medication. For the more serious dysrhythmias, we have digitalis, which they will use that in the hospital. Week 8, we're talking the mechanical aspects of the heart. Here's where we talk about high blood pressure. And there are certain medications. There's a list of about 7 or 8 different drug classes that we use for high blood pressure, to include ACE inhibitors, diuretics, calcium channel blockers, beta blockers. I can't even think of all of them, but we will talk about some of those during week 8. You might see that. You might not. We'll see. But basically, I'd just ask you, what are some drugs to treat cardiac problems? Of course, you know, if you see an antibiotic or something on there, that's probably not correct, right? Okay, we're going to get into more detail here. I'm not going to go into this too much because we'll cover it more in week 6. But basically what I just told you, anticoagulants to keep the blood from clotting, antiplatelets, also same thing, vasodilators. I didn't realize I had more slides on that. Digitalis, it helps your heart pump better. So that's why it's usually somebody, maybe the heart failure would probably get Dig, which is what we call it. Antidysrhythmics, I just talked about. I take flecainide. Amiodarone is another one. This one is much more common. Flecainide is a little bit rarer, but amiodarone is going to be a very common medication. You're going to see that a lot when you get to your clinicals. And then here is a list of all those blood pressure medications, or at least some of them. When we get to week 8 and we start talking about blood pressure meds, we're only going to talk about a few of these. I want to overwhelm you. Probably about maybe 4 or 5. We'll definitely talk about diuretics. We'll definitely talk about beta blockers, because those 2 are given out every day in the extended care facilities. So these are some you might want to know about. Now, when it comes to nursing management, that depends on what pathophysiology they have. Since we're just doing anatomy physiology, we don't have any pathophysiology, so we don't have to worry about nursing management on this one. Yay! And that's all I have. Does anybody have any questions on anything we've covered so far? I am going to point out that you want to start paying more attention to pharmacology. We are going to emphasize pharmacology more. That's an area that I know I have been falling down on. And as a group, we're trying to make sure that we hit the pharmacology for each pathophysiology as we go through. So that's why I'm exposing it to you now. And then when we get into week 6, 7, and 8, you're going to get into more detail on those drugs. So get familiar with them now, because eventually you're going to need to know more detail. And again, I want to emphasize, learn about the drug class. Don't memorize everything about Lasix. Know what diuretics do. Don't memorize everything about metoprolol. Just know what beta blockers do. Because then when someone comes along in the hospital and they say, here's a new drug called bisolol. Oh, brisolol, what is that? Rather than having to memorize, the 800th drug you've been exposed to, you go, oh, it's a beta blocker. Well, I know what beta blockers do. So you know what brisolol does. And I run into new drugs every day. Every day, there's a new drug coming out. But if I know what family it belongs to, I know what it does. And I know what the major side effects are. I know what the contraindications are, et cetera. Okay, that being said, anybody have any questions before I stop the recording?
I have a question regarding this week's assignments.
Okay,
Carl,
ask me that after I stop the recording.
okay.
Any questions relating to the material I just covered?
No questions.
Go ahead.
Oh, no question.
Oh, no question. Okay,
I have
I'm
a
stopping the
question.
recording then.
No, wait, I have a question.
Okay, go ahead.
The medications for our patients that we are going to have, will we be using a lot of those? Because we have
Yes.
13 medications that we have to do for our med cards. So would those be included in our med cards, or will those be added on?
Okay, I'm not sure I quite understand what you're saying there.
We have our med cards to do,
Yes.
and I was just wondering, for medications, will they be the same as what our patients are on? Or will you be adding medications as far as,
Now, when you say doing your med cards, are you talking about doing them in pharmacology? Or are you talking about?
oh,
doing
yes, the
them-
ones doing in pharmacology. So I was just wondering, will you be adding on more medications?
The only time, I'm not going to give you med cards in med surg.
Okay,
But when you get to clinicals, you will do a med card for every drug your patient is on. So hang on to those med cards, because the more common med cards, the patients are going to be on basically the same 20 or 30 meds everywhere you go.
okay,
But they may have a couple that you haven't got a med card for. You probably don't have a med card for Miralax yet, or Ducosate,
okay.
or Senna.
Okay,
And
that's
just
what I
about
was asking.
every patient in an extended care facility takes all three of those. So,
Okay.
any more questions? Okay, go ahead.
I have a question about your office hours.
About the what?
Office hours. When
Oh,
I can
okay.
meet
Save
your
that until I stop the recording. If there's no more
Okay.
questions on the material I just covered, I'm going to stop the recording now.